And welcome everyone to this afternoon's webinar. It's hosted by Solihull Safeguarding Adults Board and Solihull Adult Social Care. Today's session is going to focus on fire safety and hoarding, and we're really happy to be joined by Ryan Forrester and Kerry from West Midlands Fire Service, who will be delivering the main kind of presentation. Before we begin, I'd like to introduce Fiona Bateman, who is the author of the current and Safeguarding Adult Review that we have in Solihull. Fiona is going to share a brief overview of the SAR and its relevance to today's topic. Just a quick reminder that this session will be recorded, and thank you again for joining us, and I'll pass you over to Fiona.
Hello everybody and welcome. I am going to be extraordinarily brief in this review, but only because I think it's far more important that you hear from Ryan and the rest of the crew at the West Midlands Fire Service. The review that I've been asked to undertake hasn't yet been signed off. It's due to go to the board tomorrow. So this, they wanted to kind of give some understanding of why this topic is so incredibly important and why it's so of the moment, I suppose, in respect of Solihull's priorities going forward for this year. So I was asked in March to undertake the review, largely because sadly in December Anne, and it's a pseudonym chosen with her family's permission, died in a fire in her home. As you'll see, she was 70 at the time of her death, and she had been known and was in receipt of services because of hoarding disorder. She was, and I think it's really important to remember this, that she was also incredibly active. She was somebody who was described as the centre of her community, really good, close network of friends, family that loved and cared for her. She took pride in her kids, her grandchildren. In her presentation, she always presented immaculately and was described by quite a number of people as talented, artistic, with a passion for gardening, baking, and a keen crafter. Her family have been really actively involved in this review and really wanted to kind of hammer home, I suppose, the role that we all play, including, family and support networks, in helping people make safer choices. So just in respect of, of course, and a lot of what Ryan's going to talk to you about, we know that adults with hoarding disorders, but also those who have other impairments such as physical or mental ill health, learning disability, sensory impairments that might make it harder for them to get out if a fire occurs, are far more likely to be involved in fatal fires. So for that reason, it's in big bold letters there, it is really crucial that fire safety becomes part and parcel of business as usual for any risk or needs assessment. It really does save lives if you're thinking about it in an everyday context. The review, as it stands, the work that we've done and the work that we've done with the practitioners as well as with her family and senior managers really shows that actually Anne's support plan complied with your local policy and good practice. There was real care taken by the practitioners in Anne's case to think about her capacity and to manage that conflict between her physical safety and her psychological safety in dealing with hoarding behaviours. There was also quite a bit of evidence that shows that people are aware of hoarding, but that actually the next step is now needed. That move from being aware to then understanding how to implement a multi-agency response. That's not yet firmly embedded, and is not firmly embedded within training programs. A lot of the organisations involved in this talked about not having sufficient capacity or expertise and feeling like this is something that effectively someone else should be managing because it's just really difficult. Actually, what all the research, what all the good practice shows is this needs a whole systems approach. Everybody involved with that adult needs to understand how to work effectively with that adult to manage that sometimes conflicting risk around hoarding behaviours and fire safety. There was a really important point made by Clouds End, who were part of the panel, that if we go in with a this is really dangerous, this is really, and looking at the physical safety it can put additional psychological pressure. So we need to celebrate the small steps. We need to have that really expert advice from Ryan and his teams in those discussions to think about actually how do we manage those conflicting risks with the person and keeping them at the centre. There are a lot of guidance and assessment tools available. The work that's been done by Solihull Safeguarding Board is really good, and West Midlands policy is, and the on self-neglect provides that kind of basic framework. There's also some really good evidence of data being collected to show where the strengths are, who's good at recognising this and working together. But they're green shoots. There needs to be a much bigger understanding across providers, across those going into people's homes, around how you work collectively together, so that this isn't just on one person or the family or one set of professionals. It is really seen as something that the whole professional network and does with the individual to kind of take it forward. There are a number of recommendations that we've made, and I'm happy to report that there is already work underway, both locally, regionally and nationally as a result of Anne's Safeguarding Adult Review. It's not yet signed off, but actually there's been a huge amount of activity already undertaken. So I know that you guys are taking this really seriously. I'm really grateful for the opportunity to talk to you and just talk a little bit about Anne and why this matters. But as I said at the beginning, it's much more important that you now hear from Ryan. So I'm going to stop and then hand back over to him, if that's okay.
Yeah, thank you, Fiona. Thank you, Kirsty, for that opening. So if I just share my screen first of all, and then I'll go through various introductions while we're here and what we're going to be doing today. Someone just let us know if that pops on your screen, please.
Yes, that's up. Thanks.
Yes.
Okay.
We can see the slide, yeah.
Okay, I'm Ryan Forrester, Station Commander from Solihull Fire Station. Kerry is going to be supporting me today, who's also from the Fire Service, but a prevention department. So rather than steal her thunder for when the part where she supports me with this presentation, I'll let Kerry introduce herself when she comes to the part where I hand over. Just in terms of admin today and what we're aiming to do, if you wouldn't mind everyone leaving mics on mute throughout it, just because there's a lot of people on the call. Any questions, preference would be to save to the end of it. However, I'll realise as we go through the presentation, there might be some pertinent ones that you need to throw up. If I don't see them on the screen, feel free to just overshout me and I'll try and answer them as we go. The main aim of today is to look at obviously hoarding and fire safety in the home and what we can do both as a fire service and then kind of collaborative as partners, really, because this won't touch on that specific incident where unfortunately that lady passed away. It's not a case study of that. It's more the outcomes and what we can do and what you guys can do and be aware of moving forwards. So if we start off with the basics, I'd envisage, I know we've got an hour booked. I don't see it being that long. I'd go 20 to 30 minutes maximum, and then we'll have time at the end for some questions. So we should be able to get everybody's questions answered. So fire prevention in the home, obviously, that's a big part of what we do. We don't just aim to do the response element. We also aim to try and prevent them happening in the first place. And today we're going to be predominantly focusing on house fires in the home, as opposed to commercial sites or care homes or sheltered accommodation or housing, although they all are one and the same in terms of risk of fire, really, in certain elements. So we're going to be looking at how to clearly recognise the individuals that are most at risk of harm due to fire, what we can do to try and prevent that or prevent serious injury, death from fire, and also to try and recognise every partner can do a bit in terms of identification, when it's applicable to refer to us, and then what we do off the back of that referral. We will not really be touching on the SIR process. That's very similar to what you've gone through in terms of the outcomes from the SAR. We call it SIR. It's essentially the same thing. So you'll have to forgive me if this sound does not work through this clip, but if it doesn't, it's not too important, but hopefully the video will come through. So it's a quick video just to show that even in any type of property, there can be environmental risk, even if it's potentially well kept, on top of what we'd see as a chaotic lifestyle or hoarded property. And we can look at some of those examples now. So the idea of this picture is you'd be surprised. I've been to quite a few incidents where someone might stop cooking, finished dinner time, so to speak, throw some tea towels on top of the still hot oven or hob, washing baskets, things like that, kettles even, and forget that it's hot. And then it can start fire. The washing machine and dryer is just to essentially show it can be accidental and electrical as well. Obviously we see those. The detached smoke alarm is just to say there is no warning. If you've got a detached smoke alarm, keep it working. The close one is just too close to a heat source. Nice and simple stuff. Essentially, close right next to getting something like an external heater can catch fire. The candles, again, might seem basic stuff, but you'd be surprised how much we see that, where candles are lit underneath net curtains or curtains or anything that can catch light, essentially. The socket one is basically overloaded sockets. So what we tend to see a lot is strip adapter into another strip adapter, or bent round a room because they want 9 meters of cabling, so they daisy chain all these adapters together, which essentially draws too much power to what it was designed to do in the first place, and have tons and tons of plugs on it, which can cause overheating. So it can be an issue, especially if they're not separately fused, your lower end market kind of adapters. Then we've just got pictures of kind of a chaotic scene or hoarding, just to say there's more stuff to burn, quite simply, and obviously it presents more hazards, as we'll move on to in a bit. Oxygen, that's just, we really need to know that, to be honest. If it's kept on site in a property, we would really need that info. Now the reason for that is obviously my role is in operations. If we attend any kind of incident, not always, but a lot of the time, we have what we call an MDT. It's just a small computer on a fire engine that will flash up with any relevant messages we have on record of said address. So I don't know, 10 Coronation Street, you know what I mean? Albert Square for you East Standards fans out there. Flashes up like that, and then it would say if there's oxygen at 12 or 14. So we would need that information to know there's a risk of oxygen in this fire, which is going to accelerate it massively. So we like to know about oxygen on site. And then there's just a few burn images below of that kind of thing. Moving on to hoarding specifically, obviously it presents an element of risk and danger to all those involved, on top of the basic elements we've just touched on. Okay, so that's a typical scene we might see there, and I've no doubt some of you guys on the call will see that as well. And then it's about those kind of behaviors, the reasons behind it. Is there a struggle to maintain things that we can help with? Is there a struggle to potentially clean up, tidy up, mobility, anything? It's kind of the reasons why we try and help out, is to find the root cause. Believe it or not, a lot of partners think that the fire service have some legislation to back them up behind someone's front door to go, well, can't you go in as a fire service and just say you need all this out of there, we'll make it happen? The answer is no. The fire safety order really is for commercial and businesses, more in line with housing authorities, sheltered blocks, as opposed to behind someone's own privately owned front door. So we are also very handcuffed when it comes to making changes. And it's been proven anyway that the best approach is not to go in and just say, I want everything out of here tomorrow. It doesn't really work. It's going to happen again. You're best off going with an educational approach and a supporting one to try and kind of thin it out over time. But we don't have any legislation. That's what also makes it challenging for us. So in terms of what it is, hoarding disorder is when an individual acquires an extensive number of items which are stored in a chaotic manner, usually of little monetary value, not always, and not always chaotic as well. Been to a few, hoarding incidents where it was very well maintained, 10, 15 televisions, stereos in that section, etc. On the 1st of October 17, hoarding disorder was added as a category by the World Health Organization. It's classified as a mental health disorder. Now, building on what I've just said there and about the legislation, it depends how you work in your local authority area about what you can do and powers. Okay, so If I take two examples here, and it's not to say one's better than the other, I'm just giving you real-time examples of what kind of happens and what frameworks are in place for us. So we obviously cover the whole of the West Midlands, and depending on that local authority area, things might change about how we work and how we deliver. So for example, for a number of years, I think it's still there, but Coventry had a designated team over there. I think it was called Enabling Spaces, which were 2 people trained with a background in hoarding. And we would also work with them and probably see them as the primary go-to for support, because they would pick up the elements we are not qualified to do, i.e. mental health or cognitive therapy interventions. We are environmental risk and usually recommendation. We're not always enforcement and or specialists in mental health. So although I'm going to come onto a role where we do better than that than we ever have, it depends. Whereas Solihull, there isn't a designated team as it stands, but we have a number of things working out of. In fact, the Clouds End, which was mentioned by Fiona earlier, that ran out of Solihull Fire Station as a community group for a number of years. And Heather Matawatsu, who sits over that, essentially is heavily involved in lots of regional policies, so kind of gets where we come as a fire service. So it kind of worked, and we would ask people in Solihull if they're open to do so, because obviously most people, not all, but most, if they're going to be a hoarder, will probably be very private and protective over it rather than come to a group and share and talk about it. Although this group did act like that and does, to try and help people, and Heather would try and give said therapies to make them understand the kind of risk. So the basis of that is it depends where you are to the effectiveness a lot of the time about what we can enforce, what we can't. Some of it is related to, say, if it's vermin, etc., the environmental agency would have more influence than us. So it can be very tricky ground. But relating to the risks, specifically to hoarded properties, escape routes are compromised due to the amount of hoarded material. Fire spread and intensity can be accelerated by hoarded material. Again, that's just quite simply more stuff to burn, to keep it simple. It travels easier. If there's lots of stuff in a room, there's more what we call energy from a fire perspective. It will go faster. It will go more aggressively. That's why it's a risk. Increased smoke and reduced visibility. Usually, again, not always, but usually, heavy amounts of plastic or rubbish or papers just produces more smoke, which makes both our job more challenging, but also the person who might be involved, unfortunately, to get out of that property, or anybody trying to, rescue them, essentially. And, it can make a massive difference to a house fire. There's, remember VHS tapes? I know some of you on this call remember VHS tapes. Come on. But a few of them, a handful of them, the smoke off them is unbelievable. It produces a, pitch dark, black, acrid smoke that you can't see doing that. My John Cena impression there, that'll fly over most of your heads. But anyway, you can't see on it. So you imagine that ramping that up quite a lot. It's very difficult once a hoarded property is involved in fire. Structural instability can occur due to the weight of the hoard. Again, genuinely, these are all examples of real-time experience. Been to many a property where, say, the floor from upstairs is bowing, and you can see a dip on it about to collapse through. That's different than when we can go into structural kind of things where we can say, right, this is a real danger now. That's where it gets really complex. But there are examples of that where there's just so much weight in a building or a room. Poor condition of property can lead to structural damage, leaks, electrical faults, which pose a danger. Again, sometimes we have been to, and again, I'm just naming examples, but to help give that context, a block of flats, water leak from above to a flat below. They say it's coming from above me. Agencies go in to try and get to it. There's no way they're going to be accessing any, pipes, and to try and do remedial work straight away can cause right issues because they don't know where it is. Also, cabling, electrics. If you go to the, what I showed you earlier with the overloaded sockets, a lot of the time they're buried under somewhere you can't see, more prone to overheating, more difficult to get to. And we see a lot of partner agencies struggling, electrics, gas, plumbing, to do those elements of the role due to a hoarded property. And then obviously the health hazards alone. So in terms of clutter image, that is just quite simply a scale. You know, it's obvious where we go. It just gives a visual degree of us to try and pass over what we essentially see as. I mean, one don't look that bad, does it? But but you can see with 9, yeah, we use a popular tool is this hoarding scale, and it just gives you a brief view of. Eventually, if it probably starts at 3, 4, and you see signs of 5, 6, it will more than likely, whether it takes weeks or years, it might end up to 9. So we're trying to prevent that with referrals. So how do we do that so far? Just before I go on to this bit, little break there. Any questions so far? Happy with the pace? Does anybody need to check anything in, or are you happy for me to carry on? All good?
All good, thank you.
Right. Okay. So what we've tended to do is over the years is safe and well checks, formerly home fire safety checks. Okay. And the way we've delivered these has changed over the years, and I'm going to touch on some of those now. So some of you will be aware that we have had several roles which have worked in line with operations. So it was previously called VPO, which was Vulnerable Persons Officer. Some of you might have heard of them. It then changed to Complex Needs Officer. And it's important to give the context first about why it moved to this and how this works now. So those two roles were essentially one and the same. What the bulk of that role was operational personnel, firefighters, crew commanders, etc., essentially doing another role really on their day off, to engage with someone. Because if you go on a fire engine, there's a high likelihood you might get an incident. And I'm sure some of you on this call will have had some kind of intervention, maybe where you've gone, fire service ain't turned up again, and it's probably because they're at an incident. But that was happening frequently, and not only was it letting the individual down, but also you as partners. So we moved to a brand whereby on their days off they could move into this role, be undisturbed, deliver it, and also working like a case load, like some of you guys do. So some of these visits to these cases that we've gone through will need 3, 4, 5 visits over a series of months. You're not going to have one chat and then solve it. You're going to need to work on certain education things. So it's eventually up to modern day called prevention officers and practitioners. Okay. And what that is essentially a standalone role, full time, which provides interventions to deliver improved safety to those identified as highly vulnerable. To us, we deem that as vulnerable from fire, greater risk and less capable of managing their own safety, assisting identifying and engaging with partners, carers and or stakeholders. So that role is designed to engage with you all more. So as I've said for reasons before, fire engines would go out and they might have to go on an incident. Then you're left there doing a visit, and perhaps it's a non-loan visit and you can't go in on your own. Waste of your time, waste of ours, let down the end user. It's what we're trying to avoid. We work with children and young people wish to show an unhealthy interest in fire. Not relevant to today's presentation, however, to touch on it because it's there. Essentially what that is, if you're unaware, this role will also do what we used to call, still kind of is the same educational program, junior fire setter tutoring, and that's what it was known as before, if you knew that. Essentially, if we see people under 18, especially younger, who have a fascination with fire or start to start fires, we try and do some interventions with them, usually in their school environment with a teacher present. Can be at home as well, but it's predominantly in the school. The reason for that is again to engage them and try and show them the dangers of fire. So from your very little ones, like little card games showing the risk, to your older ones who are more in their teens, showing them what can happen in a bit more graphic detail. It's not that graphic, don't worry, but it's just you get this scale of how we try and do it. And then educational delivery for children and young people with special educational needs, which we also do. So assessing the risk factors for fire adults, just can run through some of them. These are some of these things that you might see in a home that we won't unless we've been there. And by that, while you're just reading through those, because I won't insult your intelligence to read them all out one by one, what I would say is yes, we are quite good, I think, at engaging with the community and getting beyond the front door, but not always. If they don't want us in there, we have no powers of entry. In an incident, we do, and we have powers of entry to wherever we want to go, pretty much. But if there's no incident happening, we don't. So if an occupier of a front door of a home they own say, I don't want a safe and well check, thanks, we have to go, okay, that's it. We cannot enforce them to have one. And some of these are just some of the things that you all might see that might mean you refer in. We'll come on to the referral process in a bit, but just to touch on some of them in case they don't make sense. Flammable creams, no working smoke alarms over a sustained period, especially, you know, they're not going to fix them. Smoking discarded materials, burns on carpets, bedding clothes, previous near misses. Or we call them near hits. You might call them either, but essentially near misses. So, you know, you might hear a story one day. I had a fire last week on the cooker. Yeah, I put it out with water though. It's fine. And a lot of times we see partners just leave that. Well, we're at that point where if they've had ones like that and it's kind of a near miss, perhaps refer into us, and we'd probably go down, hopefully, a more educational line to say, this is what caused it. Not always, it can just be accidental, but you know, there are some times where we kind of need to know stuff. And a lot of those are kind of our red flags. You don't really see chip pans anymore as much, but you still do. You know, the reality is you still do. And people still tackle them wrong to this day. So we try and come at a different angle from that as well. So in terms of the terminology here, I wouldn't get bogged down too much with, to be honest with you, and I'll explain why. Any partner's kind of route in is essentially the same. You don't have to worry about, oh, I need one of those PO officers, or I just need a base level safe and well. It doesn't matter. Whatever you're referring for will find its way to the right place in the fire service, if that makes sense. Usually, 9 times out of 10, a safe and well referral comes in, an operational crew will go and complete one with the basis of general fire messages, a little bit of investigation, smoke alarms. If they leave that property and they're like, there's loads of risk here, but I haven't got time today, that's when we refer to one of those PO officers. So whatever you're referring in for, don't worry about outreach. You know, you just got to go, I'll refer to the fire service, it will find its way to where it needs to be. But essentially what that team tries to do, very complex needs that increase vulnerability to fire for some of the reasons we've touched on already. The need to engage with multiple agencies. In other words, you know, there's a partner approach going on. We will require further interaction visits to reduce the risk of fire. Requires tailored support. I'll come on to them in a minute, actually, because I was many years ago now, was a VPO role for a number of years. So I'll tell you about some of those in a second. Personal risk, and I'll touch on here. These are just some of the main issues again, and just to touch on some of them. So why and how some of them. See, living alone, isolated, just more people, you know, in the house to make aware of a fire is less likely to have than someone living on their own. Smoking in bed, hospital airflow mattress, careless disposal, oxygen, substance misuse. That's more about your ability to respond to an incident such as a fire or smoke alarm, as opposed to just that as a standalone issue. Dementia, mental health, learning difficulties, sensory impairment. We're looking more from that angle, like prescribed drugs. Are there any impacts that make them really sleepy or make them very drowsy? Things like that where we might need to have a look. Signs of previous fires, again, just flammable creams. So what we offer to support with sensory impairment, we'll come on to in a second. Safe and well visits. We've already touched on some elements of this, so I'm going to fly through this bit, to be honest. But essentially what they are is just a person-centered approach where we try and give fire safety advice to someone in their home. That's what they are. And we'll give equipment where we think it's applicable. And we'll come on to the equipment in a second. And it predominantly, nearly always, but I'll always use that as get out. So it's not always, but it's free to the service user and or you, the partner. So we normally take the cost for it, but there's sometimes where we would advise partners, but it's very rare. So the equipment that we offer, and this is where I'll touch on to some of them real life examples that I just mentioned in here. Okay, so I wasn't ignoring it. So some of this might look a bit weird, but I'll explain why. Smoke alarm top left. bedding, hearing impaired alarm, smoking apron, bin or bucket, and a mat. And what are they there for, right? Well, fire alarm's obvious, but what we did for years was, as an organisation, you will not smoke in bed because that's what we want you to do. Let me tell you, in that VPO case I had once upon a time, a gentleman told me back, expletive, rye, expletive. Yeah, I'm not doing that, expletive. You ain't going to win with that kind of behavior. So the idea was, okay, you're not going to stop smoking in bed. I'm not encouraging you to do so, but if it's the only thing I'm going to do to make you safer, I'm going to offer you this fire retardant bedding. I'm going to offer you this fire retardant throw, which is designed to a really high inflammability level. So in other words, it's harder to burn. Everything in the world will burn if you put enough temperature to it, enough heat to it. But the idea is you are less likely to have a fire in bed if you use this type of bedding, because we're not going to change them behaviours. But our primary aim is to stop it in the first place. But if we can't, we're going to go with something like that. Hearing impaired alarm. That is, I'm sure most of you have seen these, but if you haven't, that is a vibrating pad that goes under the pillow. Okay. For someone who can't hear the smoke alarms, we'd still leave them up anyway. Number one, it links to them, so they need to be there to detect the fire. Number two, it will still alert someone, perhaps neighbours or stuff like that. So we'd still leave them up, but they get when they're in bed especially, they'd have that alarm. The last three might seem a bit odd, but again, I'm going to use real-time examples because it's just better. That's a picture of a lady looking very happy with herself there with a cigarette in the wheelchair. Can't fault her. However, this again is a real-time example from several years ago and why that came about. So I went to an incident in Coventry whereby there was a lady with 23 out of 24-hour care. And you probably know where I'm going with this. In the 1 hour she was left alone, she was left with her smoking materials. She dropped the cigarette in the wheel arch of the wheelchair and herself and couldn't reach it. And unfortunately became a fire fatality. So that wasn't a nice one to attend, probably avoidable. But again, we was like, well, if you just had one of these on, it probably would have, saved your life. Not for certain, but it probably would have done a bit better. And we can help with care plans and stuff like that. That's where the PO comes in. They'll be more built into advising things and recommendations in care plans. Again, the big metal bin, again, it might seem a bit random, but for context, that chap I was on about earlier, smoking in bed, he had a diagnosis of MS, and he used to shake violently while smoking. So he missed the ashtray all the time. So in the end, we said, if I gave you this massive target to put them in, would you use that? Yes, I would. And although it doesn't solve the problem, and we always give it with the concept of this doesn't mean we want you to do it, but if you're going to do it, try and be safer. And it did work with him to a large degree. So that's why. And then a mat is just, you're going to get people with, say, smoking chairs where they never move ever. And it's just their life. They're just ingrained in that. We'll put that in front of the chair, for example, to try and help out and reduce the risk. Real finish up on equipment for my last slide or two. Smoke alarms fitted on each floor of the house. That is something we advise. Just they need to be one per floor of your house. 3 floors, you need 3. 2 floors, you need 2, etc. And in some cases, we'll fit more on a floor. In rare cases, usually 1 suffices per floor. Hearing impaired alarms, just been through those. Test smoke alarms once a week. Batteries run out all the time in them. Not so much more in your hardwired ones, to be honest. They usually go for many years, but if you don't test them, you don't know. And all that equipment that we've said and I've touched on there with examples is usually free. Finally, for me, before I hand over and then come back towards the end of it, just a thing to know, basically, for you out there, doing your home visits or whatever you do. These are things that we offer. So touching onto that mental health aspect, or someone who's forgetful or dementia, they live at home and they cook. We see a lot of incidents where they forget the gas is on. We just advise, and Caden will fit this for us. It's basically a massive yellow switch with a key, okay, to keep it simple. But it's it's not a fail safe, but it has shown, evidence shows that it is really good at its job. In other words, next to the cooker usually is a massive yellow key, where if someone's going to cook, they usually turn the gas on and off via that route rather than forget. So, you know, you can have some signage up to it, next to it, and all sorts. So that is coming towards the end of my bit. What I will do, just looking at, there's a question slide at the end. If you've got any questions for me so far, I will come back and answer those, so please note them down. But for now, in terms of referring into us, I'm going to hand over to Kerry. So if Kerry's still there, if you wouldn't mind, Kerry, I'll just jump it over to you.
Yeah, good afternoon, everybody. Thank you for inviting me to this webinar this afternoon. My role within the fire service, I'm the business partner for partnerships, so I support all of our partners to refer into us as a service. But I also want to say a big thank you for inviting me, because part of my role as well is I support the serious incident reviews that we look after at the fire service. So Ryan obviously did touch on them, but we're not going to talk about that today. But I will say that the case that this has come from was my case that I took to the board, and obviously it's really good to see this kind of loop of support that's now being put in place to make sure that everybody is aware of the incident and how we can learn from it all together. So yeah, it's a big thank you from me. So what I'm going to do now is I'm just going to go through how you can refer to us. There's 3 different ways in short, so I'll touch on all of them. I'll explain them all clearly. And then what I'll do at the very end, I'll put my email address in the chat, because I know there's a lot of people on this call today, and some of you may know about our service, some of you may not. But if you've got any questions, or you do want to link up with us as a partner, you can then contact me directly. Okay, so how it works for you. We can set up a bespoke link, and what that has is it has a 4-digit code within the link. Basically, that means that when you refer into us, we can see who's referring to us, how many referrals we get. If you would like that data shared back to you, so if you said, right, well, actually within my team, I want to know how many referrals we've sent over the last quarter, we can set that up for you and share that data back. So it just helps us keep a track of the partners that refer into us. And what we then create is a poster for you, which has the QR code with that link in it. There's also the link there that you can click on directly from your computers, but it just means that this poster can be displayed in all staff areas. It takes you then directly to our website, and within the form you just need to put your details in, the the service user's details in, and why you might be referring to us. Now, what I will say ahead of time is that the referral form at the moment, it is something that we're looking at to simplify. From feedback that we've had from partners, obviously we appreciate that your roles are incredibly busy and that time is very precious. So from feedback, we want to try and make this process even shorter if we can. So when you do go onto it at the moment, if you do think this is, you know, takes a couple of minutes normally, but we do want to even streamline that to a shorter time if possible. So if you have any problems when you do go on our website to make a referral, that's what my role is for. You can just contact me and I can support you with that. The only thing I will say is when you go on our website, there's an additional comments box. In that box, it's where we would ask you to put any pertinent information that you think is going to be relevant. For example, if you've got a good relationship with the individual and you'd like to be present during the Safe and Well visit, that's absolutely fine. You can just pop on that you want it to be a multi-visit. It might be, for example, that you want a female crew to attend for whatever need. Any kind of request that you have, just pop it in the additional comments so that we've got that ready for when we make the booking. Okay, so that's the one main way that we ask our partners to refer. I'm going to share another way now, which probably won't be as relevant, but I'm still going to explain it. So if you ever see or hear about SafeLinks, you'll understand what it is. So for some of our hospitals, for some of our GP practices specifically, we use SafeLinks because it's a national website. And it is a person-centered framework again. So individuals, the public can go onto this website and it takes them through a bit of a home check tool that then is bespoke to their own property. It goes through every room in their house. And at the end of it, they get a bespoke PDF kind of fire safety advice that's personal to them that they can print out and save. What it does do in the background as they're going through it, it gives a points score. So as the points are created, if it hits high enough, it will still then come through to our bookings team and the individual will still then get a Safe and Well home visit if they require one. But what it means is it triages it a little bit better for us, because for some of the general public who want to Safe and Well, they're not as much of high risk as what we would be wanting to support. So what SafeLinks does, it gives them that fire safety advice for their home. through in a lot more detail. What I will say for the majority of you, if you do want to become a partner with us and you're not already one, you will have the main direct website, because that is what we encourage staff to use. This one is more for general public. So if you are a GP and you want something in your waiting room, or for example, that you want, people to self-refer, this is what we would use. The third one that I'm going to mention, which isn't displayed on here because it's more of a rare bespoke link that we create, we can also create what's called a priority pathway. So if you are a partner that is only ever going to refer high risk, and I'm going to go through that on the next slide, if you're only ever going to refer to us those really vulnerable, complex individuals with needs, we can create a priority pathway for you, which means that it's a lot simpler to fill in that form. It goes directly to our bookings team, and within that, there is a triage system that the individual has to be visited within 7 days. So it kind of prioritises it above everybody else. So 3 different ways that we've got there for you. You can take that away with you, have a think. And then if you do want to set up a pathway with me, obviously I'll share my details and you can contact me if that's okay. Okay, so everything that Ryan has explained today, this slide here just kind of summarises it for us. And what happens is when we do have a serious incident review, we use that data to collate which risks we have seen over the last few trends. When we have an incident, we will analyse the kind of things that they have had that might have been issues that they needed support with, and that's what we want to go forward and learn from and support more. So the 2 cohorts that you can see here on this slide, we've got on the left, they're the most at risk of having a fire, and these are individuals that may be in their property more, they may be single parents, for example. They're just going to have more risk of accident. So for example, a single parent might be cooking and then get distracted, go upstairs to care for the children, and the cooking is then unattended and an accident can happen. However, these individuals tend to be able to evacuate their property still. Okay. The cohort on the right are the individuals that are most at risk of dying in a fire, and that is simply because they tend to not be able to evacuate quickly. So for example, mobility issues, we would be covering things like bedbound individuals that physically can't evacuate a property independently. Obviously, hoarding is the big one that we've touched on today. Evacuation routes are then hindered and they can't evacuate properly. So if you are looking after or you are aware of anybody who has any of those risk categories on that right hand side, please do send a referral through to us straight away, and we will be able to triage that so that they can have a safe and well. How it looks like in short, as I've said, the referrals can come from yourselves and they can also come from the individuals. We accept referrals from everybody. That's then triaged by our bookings team with the different risk levels. At the moment, we offer remote safe and wells for our low risk individuals. So if they come through and it might be that their risks are already low, we can give them a telephone call and offer that fire safety advice over the telephone. What I will say is most of the safe and wells that we do as a service are still face-to-face, because when the crews telephone, they might hear things that are still a concern and they escalate it to a face-to-face visit. So I think Ryan would agree that my knowledge of what crews are still doing, we do majority of them face-to-face because we think it is a more detailed service. But the high-risk ones are obviously the ones that we want to prioritise, use our time effectively as a fire service and ensure that we see those first. I have put in brackets there, as I explained previously, if you want it to be a joint visit, that's absolutely fine. Following the safe and well assessment, obviously the outcomes are that we give advice, we provide the equipment, or like Ryan said, we can refer on to our prevention officer team, which are more dedicated and can give that longer term care. So what I'll do is I'll share my details. If you're not aware of our referral service, please do get in contact with me. For me specifically, NHS and any kind of healthcare providers, you're definitely partners that we want to engage with more. Anybody who supports safeguarding, again, you're somebody that we want to engage with. So please do contact me and I can help. Thank you for your time.
Amazing. Thank you, Kay. That's awesome. Just to support that, to finalise everyone as well, Kerry's role covers a lot more and a lot wider than just Solihull. So I'm happy, and I'll stick it in the chat shortly. If anybody's got any fire service queries about anything Solihull related, then feel free to come to me as well. So I'll drop my email and details in the chat shortly. That brings us to the end, really, of this. presentation, and we touch on some areas. As I said, it wasn't case specific, but hopefully we've covered a lot of areas. If there's any questions on anything we've covered or other stuff, either I'll answer it now, or if it's for Kerry, let us know. Or if I can't, I'll get the answer to you and come back if I don't know. Go on, Kerry.
Yeah, I don't know if you can see my hand, Ryan. I was just going to answer one of the questions that was in the chat. So somebody has asked if we only accept referrals on consent. So what I'm going to explain here is that what we would say to all of our partners, if you've got an individual that you're concerned about and you've explained, we would recommend you to explain what the safe and well offer is. If they say, no, I don't want anybody in my home, thank you, I'm fine, but you still have that concern, we would still please encourage you to send that referral through to us. Our systems are secure. We don't share that information. It stays on our system. And the reason why I say that is if in a month's time that individual has a fatality in a fire, we would then look back and see who has referred to us, who hasn't referred to us. And obviously in the case that has been mentioned today, that's where a lot of this came from, was that about referrals and the importance of referring to us. So we would still highly recommend you send that referral through. The crews won't be able to do the safe and well without their consent. However, what we've got from experience is that sometimes you can catch people on a good day. Some people who are isolated from their community do feel very lonely, and it might be our crews are very dedicated in trying to approach and reach individuals. So even though they might decline the appointment over the telephone, our crews will have a 3-time attempt, and they will try and call 3 times to book that visit in, morning, afternoon and evening. They will then even do a drive-by sometimes just to see if they can go by and knock on the door and catch them on a good day. And in experience that does happen, and they will let them in. But as I will say, please do send the referrals, because then we can have that kind of on our system that we're all doing our best for those who are vulnerable.
Cheers, Kerry. Thank you. Any questions on anything, anyone? We'll try and pick up the chat ones in a bit.
Okay?
Yeah.
Hi, my name is Yvette from Mostly One Hospital and work for. So I'm a physiotherapist, but then, my colleague, the occupational therapist, usually do access visit before patients has to be discharged from our unit. So is it possible to make a referral even if the patient's not in the house? Say it's hoarded, that there's a risk of falls and some other risk, like as you said, is the fire, the safety of the patient. Will you be able to pick that up if the referral has been sent to you, if the patient's still with us?
Yeah, the answer is yeah, in short. However, we'd prefer the occupier to be there when we're conducting any visit. It's not always possible, but we prefer that. However, if in some circumstances we will do, if that person's really dependent on someone else, a responsible person, a specific contact, a partner organisation, there are also instances where we could do a kind of risk assessment, which is essentially what a safe and well is, prior to them being discharged. So there's a number of options, but in short, yes, you can kind of refer any time, and then as Kerry stated, we'd kind of triage it as it came on, into dependent on need.
Okay. Well, thank you very much.
Thank you. Lisa.
Thanks, Ryan. We had a patient who doesn't really go out much, and he orders a lot on Amazon, so he has a lot of boxes from there in light of the bin strikes, not collecting recycling waste. What can we do to support him to be able to get rid of the amount of cardboard he has, because he is a smoker as well, so that it's a massive risk factor, other than putting it in our boots?
Yeah.
Taking it.
A lot of the time, for whatever reason, I don't know, but obviously it's probably because of what we do. What we tend to find is, again, not always, because there's never a one, fix for all, but if we receive that safe and well referral and kind of come out with any partner attached, such as yourself, Lisa, and do that kind of safety messaging saying, really need to get rid of this cardboard because of XYZ, we've seen XYZ, they're normally receptive to it and work with it. And then if it's in line with and escalates to the PO role, which we mentioned earlier, there's probably lots of things we could do to try and make that happen. I've seen us take multiple angles on cases such as this, charity donations, skips. We don't very often pay for skips, but it depends. It's really complex ground and we haven't got time today. But if it's a housing authority versus the rules of their tenancy, there's enforcement, versus if it's just privately owned, we can only really encourage unless there's an environmental risk. That then will lead to the Environment Agency. So it's really difficult. Essentially, it's going to be advice given and try and make it happen, unless it falls under one of the parameters I've said for enforcement, which very, very rarely comes in, but can sometimes for us. So it kind of, as cheesy as it sounds, all starts with the initial referral for us to go and risk assess it and give advice on what we can kind of do, what we can kind of offer. I know that's kind of a get out answer, but it's kind of the reality, really. We don't know until we get there.
And just to reinforce, we can do that without the patient's consent.
Yes, we can. There are times, obviously consent is always preferred, but we as an organisation have certain legislation where we can accept them without. And in some aspects, if the risk is high enough, we'll try and do something. Because at the end of the day, we have to try and prevent something happening if we can see it from happening.
Because he definitely didn't give consent. He's got capacity, but it is a risk. Okay, thank you.
Thank you.
Not
sure who's next.
Yeah, it's Vivia here. Can I ask a question?
Yeah, of course. Hi, Vivia.
So it's in relation to buildings contents insurance. Actually, I'm sure I heard something somewhere about the potential for invalidation of buildings contents insurance where somebody's not adhering to fire risks. Just wondered whether you have any information in relation to that.
Yeah, very little is the answer. We wouldn't get involved unless there'd been an incident. The only time we really get involved with insurance companies is if they want the fire report. If one happens, the process they have to get that report, and then our findings, whether it was accidental, deliberate, etc. In terms of advisory, of course, if that, we wouldn't be getting into their insurance agreements and saying you will violate XYZ. We'll still make the safety recommendations regarding what we're going to make anyway. The only terms it would get to buildings contents insurance and we get involved would be if it was a commercial site. We might offer written guidance to say we need you to do this. Housing authorities is a bit different. If it's owner occupied home, then it's kind of, we're going to give the same messages whether they're insured, not, or whatever their insurance says. So it's very rare we get involved with the insurer.
Thank you.
Hi, Anne.
Hi, I'm an occupational therapist in Solihull, and we often get a lot of requests for ramps for mobility scooters that people have maybe self-purchased that they want to charge in the home. And obviously that to us is, it's a fire risk, and we would always advise that they're charged in a scooter shed outside, or the battery is actually removed and charged separately. Do you get many fires or incidents with mobility scooters in the home?
Yeah, quite simply. What we try and do and advise there is obviously a separate location if they can, as you've stated, a safer one. But what we tend to see is as well, they're normally in a position, not always, but they're normally in a position that blocks an exit route. So next to the front door, right under the stairs. And again, we can't really behind someone's front door enforce what they do and where they do it. But we'd be saying, and we've seen it, if this happens to, for example, overnight charging overheats and causes a fire, you're then stuck. You can't get out your front door. And you might have a back door to go out of, but you might not. It might be in a flat premise. So although, again, we're struggling in certain aspects of enforcement, absolutely we would be encouraging the person to take a safer route of charging a mobility scooter if they could. Yeah, because we do see it, and especially like the scooters. The name has gone out of my head. The ones that kids use to get around on, as opposed to proper mobility.
The e-scooters.
E-scooters. You see, it barely rescued me there, Kerry. You know what I mean?
I was just going to say,
well.
Ryan, because I did see your question, Anne, in the chat, I have shared some links that take you to our external website. There's lots of advice around e-scooters and e-bikes on there, and you can pass those forward on to anybody who needs that support.
Thank you.
Awesome, thank you. Sorry, it just says Upward Care, so I'm not really sure of the name. Sorry.
Yeah, it's me, Elaine. Upward Care. Hello there. We do have an extreme hoarder. Our service provides support for various people, but autism, mental health, you know, across the board. We do have an extreme hoarder at the moment. He's got full mental capacity and continuously refuses help. We can't even get him to register with the GP to get him that mental health. So as a company, we're trying to get trained more in mental health, well, for the support workers, really. The property's in a real mess at the moment. It's got vermin and everything now crawling through the walls, which we've literally got an outside company to deal with. But would you still advise a referral, even though he is very resistant to help? He's a very intelligent guy. He talks the talk and walks the walk, and he'll say he's going to do this, that, and the other, but kind of doesn't, and takes him days to just get rid of maybe rubbish the size of a kitchen bowl, because he goes over and over and over it. So would you still advise the referral?
Yeah,
I
with that one,
personally would.
yeah, with that one for sure. What I'd say is, so we won't get knee deep into the weeds with an individual case. If you want to drop your email address in the chat or take mine, I'll try a fast forward version for that one, if that's all right, and try and sort it myself locally for a referral of some sorts, and we'll try and come out and see the gent, and you know, see what impact we can have. Certainly with that, although it's outside the parameters, so Kerry will kill me when I get off this call. However, I am going to wing it and fast. I'm going to fast forward.
No, me and Ryan we're in the same mindset. I've got, this is a, you know, we're talking because we're passionate about caring for the people in our community. And jumping on to what Ryan will say, I'll mention two things. Firstly, I think we're all well aware that hoarding is something new that we're all trying to support, and it's very hard to. And I think this is proof that, you know, change hopefully will happen, but it's going to take a long time. But everyone's got to try and support as much as they can when the individuals don't want the help. But secondly, the partners and the pathways that we create and can set up for you. I know lots of you have asked on the chat, how can we get the posters? How can we get the details? Contact myself. But what I can do is I can also set you up with a local fire station. So say, for example, Ryan is station commander for Solihull. My role at the moment is making sure that stations are aware of the partners that are within their local area. So Upward Care, for example, wherever you're based, it might be better that you are Walsall. So for yourselves, it would be really good if you have the contacts for Walsall Fire Station, and that you've got the station commander and the watch commander there who you can pick up the phone to and say, look, this individual has got all of these risks, and the crew then have got that contact with yourself. So we can also set it up so that any station that you're local to, we can create that for you as well. And then, like Ryan said, the crew can go out and support. Similar cases that we've had in the past where you know, individuals like yourselves have said, I've got this vulnerable case, and then we can go straight to the POs as well and say, look, we're going to do a safe and well, but we know that it's going to end up going to a prevention officer case, and we can kind of, like Ryan said, fast track things forward.
Yeah, cool, fabulous, thank you.
No worries. Cheers, Kerry. Yeah, if you drop us an email, I know all the station commanders round up game really well, so I'll make it happen for you. Okay.
Thank you.
Any other questions?
There's a couple of questions in the chat, Ryan, about, so if I just mention, can you advise us if a family member tells a GP surgery in confidence and doesn't want us to mention them, how should we approach the patient who has never divulged it to us?
Is that in terms of a family member trying to refer him without consent? Essentially, is that what it is?
Reads like that, yes.
Yeah. So yeah, similar. What Kerry stated earlier, we can take them, but the referrer would need to do a referral, if that makes sense, or ring out, make contact to the fire service to try and make it happen. And we'd probably more than likely use them as that kind of liaison bridge to try and make it happen. Again, if it's behind a front door where they don't want us, we're limited, dependent on where they are, of what we could do, but they could still try and refer in. All I'd say to that individual is, they're probably best off putting the referral form in the notes. I do not have consent for this, but I'm willing to XYZ, and then we can try and see what we can do.
In addition to that, Ryan, I would encourage the family to make a self-referral as well. So the family could refer on their behalf, and that would, you know, be coming from a place where confidentiality hasn't been broken then either.
Yeah.
Brilliant, thank you. I can see there's one more hand up. Yasmin?
Hi, Kirsty. I don't know if you remember me, named GP for Birmingham Solihull ICB. So there's just one more question from one of my colleagues. Would you regard a risk of eviction from a private landlord as a criteria for urgent referral? I presume they're saying that the person's going to be evicted because of the hoarding.
If it's related to the hoarding issue, yes, the eviction notice to us is kind of irrelevant in terms of the safety messages we're trying to relay. So if they still want to do a referral, yes, we'll take it and we can try and fast track it if it's a severe hoarded property. It wouldn't necessarily be like a bullet point in a referral list for us, because the risk for us is the hoarding as opposed to where they are in their tenancy. But absolutely, if it's hoarding, we'll try and, as we've done there with in the Walsall case, try and fast track it for, you know, some input.
So can I just summarize that bit? So this is separate to why I put my hand up. So especially for the GPs on the call, if there's any patients you've got hoarding and you're trying to get a safe and well check for whatever reason, you've not got consent or whatever, it sounds like it's still worth putting the referral in to have a conversation with yourselves, or maybe the PO, to see how best we can work together and try and get that patient the safe and well check somehow. So I think, yeah, a conversation, because they're not always, the cases aren't always straightforward. Would you agree with that, Ryan?
Yeah, for sure.
Yeah.
We do. Again, there's some legislation that says we can receive non-consented referrals. Our preference is consented, to be real, because we can make things happen quicker, obviously. But we can, especially if the risk is high enough, because when it starts getting to the point of, for instance, in a block of flats or next door neighbours, the risk to them who might refer themselves then also kind of impacts in. So if we're looking at a property and it's like next door's the issue, then, you know, it pulls in all kinds of other you know, council teams, agencies we can pull in. So the answer is yeah, in short, yes.
Oh, great. Well, that makes sense. Sorry, the reason I put my hand up was, yeah, as I said, I'm a GP, but you mentioned safeguarding lead. So I'm one of the named GPs for the Birmingham Solihull ICB safeguarding. I could link up with the two of you, because we are arranging some bespoke training for specifically for general practice. I am working with two of your colleagues, Gary and Sarah. But so there'd be no point in us duplicating if there's something that you're already offering. If you like the presentation you've just given, it could be tweaked a bit and sort of made bespoke for general practice, and that would make more sense than inventing something new. So if you could just put both your emails in the chat, I'll send you an email after this. Would that be okay? And we can meet up on Teams.
Yeah, Yasmin, that would be great. I've seen your name in email threads that I've been CC'd in, actually, and I believe that you've also supported kind of a self-referral text message system with the GP practices in your area.
Yes,
so
that's right.
I was going to mention that, Yasmin, if you didn't mind me sharing that. Obviously, for GP practices, we know that you're incredibly busy, but what has worked in other areas is that we've done a kind of text message service where the safe links poster that I mentioned, which can be done as a self-referral for the general public, as long as the patient list is staggered, so we're not overwhelmed as a service with loads of safe and wells, we can then offer that as an option as well, that a text message service can go out to all of the patients within your GP practice, and self-referrals can be made then. So that's another way that it can be done, and Yasmin has been proof of that it has worked. So thank you.
So there's another question in the chat from one of my colleagues. We've noticed links with neurodiversity and hoarding, for example, collecting things and not liking change. Do you have any advice?
Whatever the reasons for hoarding in the first place and the recommendations we try and make, what we're looking at is usually partner agencies to do the cognitive therapies that might be required, or that bit, mental health teams or whatever exists in that local framework. That's probably what we'd tap into for that bit. Our bit is more the environmental and risk and fire risk, of course. But yeah, in anything like that, we're probably, as much as you, going to tap into whatever service or partner we can find to help us with that bit, if that makes sense.
Thank you. Should we just take one last question? I can see Hannah's hand is up.
Yeah.
Thank you.
Mine comes from a slightly different angle because you've been saying about how to refer into yourselves. I work for the referral service within BSMHFT. So I'm just wondering if you came across somebody that was hoarding whilst you were out on either visits or something like that and they weren't known to any services. I know you said about you'd link in with them, but how would you go about getting the support? What is your processes? Because I'm not aware that we've ever received any referrals from the fire service. I might be wrong completely. I know we get some from the police and mainly health professionals because that's what our referrals say. But I just want to know the back pathway to make sure that we're not missing anybody either, because obviously with it becoming onto the ICD-11 as a mental health illness, how would you refer into those? What's your pathway? How do you link in at the moment?
Yeah, so I'll bring in Kerry in a minute if you've got anything to add on that, Kerry. But essentially what it is normally an ops crew, depending on what they know station-wise and station area, will probably have something local. So for instance, I'm obviously going to use Solihull, but for any station, it's probably going to start with a safeguarding alert, which is going to go to the adult social care to ping out anyway, duty desk. And it will probably start with that along the lines of, and or, you know, if they see signs of self-neglect or any other types of abuse, we'd probably start with that. In terms of local referrals, what we ask is, and that goes for anybody on the call. So if it's Solihull, for instance, I'm going to have to buff you somewhere else for other areas, to be honest. I can't have that much work. If it's Solihull, for instance, so we had one from the hospital where they have their own specific falls team. You can understand my dulcet tones there. FALL, that falls team. So they wanted local referrals from us, anyone they saw at risk of a fall. So we do referrals to Solihull Hospital, that specific team, but that's because they came in and trained us up in it. So essentially, if there's any partner on the call where you want more referrals from us, then we need to know about it as well, because basically the ops crews have a really specific set of skills, really, and it's hard for them to broaden it out if we don't get the input. So if you think we're missing a trick anywhere, feel free to come and just drop me an email and I'll make it happen where we can try and increase referrals to you. But they probably are coming indirectly from a lot of safeguarding alerts. I mean, as an organisation, we raise a lot. To be honest, we do raise quite a lot. So yeah, we try and encourage more partners to come and see us, and or we'd find a way to do it through other means, if that makes sense. Anything
Yeah,
on
that's
that,
great.
Kerry?
Thank you.
Yeah, I just wanted to say, Hannah, if you wouldn't mind, my email is in the chat. If you wouldn't mind dropping me a message, and that goes for all partners on this call. If there is any referral systems, like you've said, that we can send back into you, we would really appreciate knowing that as well. And the only thing I will say to finish on from myself is, obviously, I know lots of you will email me requesting a link. It might be that you have already got a link within our system, so I'm just going to send you one that's in existence. It might be that when I look, there's nothing set up for you and we need to create a new one. So obviously, you know, we will discuss it. It's not like there's one bespoke link for everyone on this call. Everybody's coming from a slightly different angle and a different department. So we'll look at that specifically when you contact me.
Thank you. Thank you for everyone who's attended today, and a huge thank you to you, Kerry and Ryan, for your presentations. It's been really extremely, informative and helpful. So thank you.